Hello, I'm Bob Chaloner, the Chief Administrative Officer of Stony Brook Southampton Hospital, and I'd like to welcome you to another edition of Focus on Stony Brook Southampton Hospital, your monthly program about the people, services, and events at your community hospital. And today we're going to do a program about a topic that's very, very important and we hear about often in the community, addiction, and some of the things that we are doing about it here at Southampton Hospital. And I would like to welcome two very special guests, Dr. Paul Garson, who is the director of our behavioral health programs, a board-certified psychiatrist, and also Katrin A, who is the nursing manager of our emergency room services. And they're both going to talk about something called, and I have to make sure I get this right, screening, brief intervention, and referral to treatment, affectionately known as SBIRT, and we'll learn what that's all about. But before I do that, would the two of you mind just introduce yourselves to our viewers, and just, I'm always interested to hear about, you know, your role, your training, and how you ended up here at Southampton Hospital. And maybe I'll start with you, Dr. Garson.
Thank you. Well, as Bob mentioned, I'm a board-certified psychiatrist, and I had been working for a long time in Jersey City, New Jersey, and in Poughkeepsie, New York, as a medical director for a psychiatric program. Right. And then I moved out here just to be out here in the summer, and found a job at Eastern Long Island Hospital in psychiatry. And then that moved over eventually into Southampton. Right,
and you've been with us for, I know, as long as I've been here, but probably
around 8 or 9 years.
8 or 9 years, okay, great. And we've asked you over time to take over a number of lead a number of our behavioral programs, and you're coordinating really a whole number of services for us.
We provide direct services, and now our program has expanded to 2 psychiatric nurse practitioners, right, and a psychologist and a social worker, and we're really expanding the program to provide the service.
And you also see patients, I know, too. In between all that, you're actually seeing patients
yes,
and needing House Lane Medical, right?
Yes, I do.
That's wonderful. And also I know you provide mental health services at the Shinnecock Health Center too, at the Shinnecock Indian Nation. So.
And also at the Rogers Center.
In the Rogers Center, that's right.
It's all under the same practice.
Exactly. Well, thank you. And thank you for wearing so many hats for us, Dr. Garson. And Katrin, tell us a little bit about yourself, how you ended up on the South Fork, and also how you found your way to Southampton Hospital.
Well, I found my way to Southampton Hospital twice, actually. I was here in 1987 when I first moved out here to be with family, and I came back in 2006 after working in Western Suffolk for many years in an emergency room. And I've been here now for 11 years.
11 years.
Yes, and I oversee the nursing aspect of the emergency department and our trauma program, and I do a lot of outreach with the emergency medical services, our EMS groups in the community.
And I know also I've gotten very involved with some of the programs to combat addiction too.
Yes.
We'll talk about that a little. And you've been very unique kind of emergency room with our seasonality, and you do an amazing job. I always marvel at how we go from, you know, a slow, sleepy little, you know, town in the winter to as busy as New York City, and you seem to manage it very calmly and coolly. Thank you very much for that. So let's talk a little bit about SBIRT. I'm just going to say it one more time so I can get it right. Screening, brief intervention, and referral to treatment. Let's talk about that. What is it exactly? What is SBIRT?
Well, SBIRT is a public domain type of program. Started around 20 years ago, and it's used to provide early identification of risky substance behavior that would not be something that a person would go and seek treatment for. For example, in the United States, 50% of the people over 12 drink alcohol. Okay?
Over 12, really?
Over 12, 50%. So if in a garden variety practice a doctor sees 100 patients, there will be 70 of them who don't drink at all or drink very socially and have no problems.
Right.
And then there will be 4% who really have a problem and anyone could see them. What this program wants to do is identify the risky drinker who is under the radar, who drinks a little too much, who might have some problems with difficulties either drinking or if their family says they drink too much, but not really to say that they have a big problem. These are the 25% that we're looking at. And if you provide a program like SBIRT, you'll be screening a large population and pulling those 25% out. Once we identify them through the screen, which is a very brief screen, only around a minute it takes to screen them, then there will be a professional who provides a brief intervention. And the brief intervention might be as much as education, understanding, and helping the person get some motivation for treatment. After that, if they have a lot of problems and they need more treatment, the IT part of it, which is the referral for treatment, is the RT,
Right.
referral for treatment. And we have groups of clinicians and programs out in the community that we can readily refer a person who needs that. So that, in a nutshell, is this form of public intervention.
So it's capturing people, not capturing them, but it's identifying people early on before they've developed maybe what would be considered a full-blown drinking problem, but early on so we can get intervention before it's probably much more difficult, obviously, if they've become that 4% of really heavy drinkers.
Right. Well, the idea is to prevent the consequences of drinking as well.
Okay.
Not so much that it's a problem for the 4%, but risky drinking has a toll in and of itself.
Okay.
It's a preventive measure, and in this case, $1 of prevention is worth $4 of treatment down the line.
Right. That seems to be, that's so true in healthcare generally. It's all
Exactly.
about prevention if we can. So.
And this really works well.
Right.
The average person who gets a brief intervention, who has a little bit of a drinking problem, 50% will stop drinking or change their drinking patterns and reduce their activities.
Right.
And we know that alcohol starts off as a very simple social activity, age 13 to 15 for many
Right.
people,
Right.
and builds up into some problem drinking, maybe in high school and college, social drinking at work. Then it gets into some binge drinking. So it's a continuum. It just
Right.
builds up and builds up. And we want to catch them early.
Okay. So we're doing this in our emergency room, and I have two questions.
That's okay.
Why the emergency room, and then what would you expect to happen in the emergency room? What would somebody actually experience if they come to our emergency room?
Why the emergency room? I think the big thing is we are a key gateway to the hospital. We see 25,000 patients a year. 21,000 of those are over the age of 18, so they are the patients that we are looking at. The average patient won't realize anything different that's occurring this year than it happened last year. We've always asked these questions. We're just asking them in a different manner to be able to quantify the data and be able to say, this can impact your health later on. Let's talk about this. Let's have this conversation.
Okay.
So if they do screen positive, they could expect that the nurse would want to have a conversation with them, which they may or may not agree to, about what can we do to help you? How can we, figure out how you can drink less? What is triggering you to drink this?
And can you describe, Katrin, just walk somebody through an average emergency room visit? Many people don't understand what happens to begin with. Most of us, fortunately, don't have to use emergency rooms very often, but inevitably we probably will. But can you walk us through the steps on just entering the ER and at what point maybe the SBIRT process is happening?
Okay, well, when you enter the emergency department, most people are starting out with seeing someone to triage them. And triage comes from the French word to sort. It's really the nurse deciding your acuity, how sick you are, so that we can categorize you and get you the resources needed. And it is during that process that we ask about your social history. We've always asked that question. It's part of your medical surgical history, and then we ask about alcohol, smoking, and maybe any illegal drugs. And at that point, after their triage, they should be seeing a physician or physician assistant, and their plan of care should be starting.
Okay. So it would be right up front during that triage process.
If they're able to answer, yes.
Right. And do we introduce the patient, okay, now you're going through the SBIRT process, or it's just
it's just
flow of questions?
Just part of our normal questions.
Okay. And just, Dr. Garson, I guess, the goals generally, and you said it's a prevention program, and it is. And what are those goals again?
Well, we want to reduce over the period of time the amount of heart disease, hypertension, diabetes, and other issues that are always worsened by alcohol. When a patient starts to drink, they don't do well on taking their medication. They become medication non-compliant. So that can cause more problems.
Okay.
As they drink more, or they raise up higher in their risk behaviors, they start to develop alcohol-related illnesses all by themselves. That's gastritis, or pancreatitis, or liver disease, and these are really a problematic thing.
Okay.
And something we really shouldn't forget about, or forget, is that there are certain other real major problems that are always alcohol-related. For example, 70% of all homicides in the United States have alcohol involved in them.
70%?
70%. 50% of all fatal motor vehicle accidents also have alcohol-related problems, interventions, as well as 40 to 50% of suicides.
Right.
So there's a whole slew of other issues that are precipitated by alcohol.
And is it true or fair to say that, we think about everybody has this vision of the chronic alcoholic, that these, it sounds like sometimes the people who are somewhere between the non-drinker and the alcoholic, that these behaviors or these health issues are occurring. You don't have to be a full-blown alcoholic in order to have these problems, that this may be something that's starting earlier with people, or?
Yes, that's true.
Okay.
When we do the screening test, which is called the audit,
Right.
which is the alcohol use identification test, you can score up to 40.
Okay.
40 is really bad, as you can tell.
Okay.
The only time where you're doing well and you get a bad score,
Okay.
or vice versa. But for people who are just scoring 10 or 12,
Right.
that starts to relate to their difficulties with these other issues, like their illnesses, or their ability to treat their other non-alcohol related illnesses,
Right.
or the other issues I told you about, the social issues.
So it is definitely prevention. I was thinking prevention from the perspective of driving while intoxicated, or cirrhosis of the liver, alcohol, what we think of. But it sounds like there's so many other preventative aspects of it also, that these other diseases, heart disease, you said, for example.
Absolutely, and alcohol is also a gateway to the other use of other substances
drugs
too. Almost all the time, you see a dual diagnosis of alcohol use disorder and substance abuse disorder.
Okay.
And here in our county, alcohol is still the #1 abuse drug, followed by opiates, and then on to cocaine. So those are the three. And the SBIRT program, by the way, can be used to screen out the opioid use as well.
Okay.
And it's frequently used that way too. It's not just for alcohol.
So we're screening in the emergency room. Are we screening everyone? Does everyone get screened? What are regardless of their condition? If I've walked in with a broken arm, am I going to get the SBIRT screening also?
Yes.
Yes. Really?
We screen everyone. We try to screen everyone over the age of 18.
Okay.
The broken arm patient is actually the perfect patient to screen, because they're able to answer questions. They're not emergently death on death's door. We're not worried about life-threatening illness with the broken arm patient. And how did you break your arm?
Okay.
Did you have a little too much to drink and fall? So we can also talk about, your drinking, and what you think is one drink might be 4 drinks. So it gives us that opportunity, and we have that patient there, you know, while we're interviewing them, and we can offer them any kind of help that they want.
Okay. So it really is a chance to just capture as broad a population as possible.
Yeah.
And
We throw in a wide
what
net.
age do you start asking people?
18. We start at 18.
18, okay.
Yes.
We should
Interesting.
look upon the screening just like we look upon vital signs,
Right.
blood pressure, temperature, pulse. You get all that. Even if you come in with a broken arm, you're going to get those screens.
Okay.
And that's how we pick up a lot.
Okay. And I guess because you're relying on the patients to answer the questions, are you at all concerned about the honesty of the answers? I mean, are these questions that, you know, sometimes people, for whatever reason, like to cheat on tests and cheating on healthcare questions. I mean, I know we talk about all the time in
Yes.
healthcare that people don't always answer truthfully. They're really the only person they're hurting is themselves. But is that an issue about people answering these questions honestly?
It can be. I mean, it can be an issue. We are depending on the patients to self-report
Right.
what they drink. We try to ask in a non-confrontational manner
Right.
because it really will only help the patient, and they're only hurting themselves by not being honest with us and any other healthcare providers that they interact with.
Right.
What's nice about it, though, Bob, they have to take the test, the screen,
Right.
and you have to read the material. So even if they minimize what they do,
Okay.
they know they're minimizing it.
Okay.
So that starts to implant it.
Right.
If their loved ones take the test too, if they
Take the tests on their behalf, you mean? Okay.
or if they go to their primary care doctor. This
Okay.
is where this test, SBIRT, also can be used.
Okay.
They see it and say, well, I'm not doing it, but my husband is, my uncle, my brother, my son.
Right.
They fit into that category.
Right.
So it just raises up the level of awareness and destigmatizes it.
Right.
When you go to your doctor's office and they tell you, I just want to see this out, it cools down the stigma
Right.
of the case, because you're not really trying to work and say you have a drug problem or a
Right.
substance abuse problem. You have these issues, and how can we help you?
Yeah, and actually, one of the clarifications I wanted to ask also, this isn't just about alcohol, this is about all substance, or it is just about alcohol?
Currently, we are screening just for alcohol, but we are in the process of implementing more substances, all substance abuse.
Okay. Are they different questions, different
Yes.
types of tests that we do?
Yeah, there are different questions.
Okay.
Yes.
Is there a drawback to screening everyone? Are people offended by these questions at all? I know sometimes when we ask questions about risky sexual behavior, and sometimes people get offended when we ask those questions. Do you ever run into that? Is that an
Yes.
issue?
Yes.
Okay.
I mean, there are people that are offended, and we don't push them, we don't press the issue.
Right.
I think that in their mind, they know that they might have a problem.
Right.
And if nothing else, that they have some kind of self-awareness that there is a problem. But we don't push anyone. If they want to refuse the questions, we just allow them to refuse.
Okay.
But at least we're having that dialogue. We're starting to break down that barrier, to have that conversation with them, that maybe this is impacting your health.
Okay. How many questions are there? How long a process is it?
A minute, maybe a minute.
A minute, really? Is that
Really
brief?
like 3 or 4 questions. It's really not
Right.
It's not complex. It's very simple. You wouldn't even realize I was asking you anything out of the ordinary.
Okay.
The way it works, Bob, we have a pre-screening test. 2 questions.
Okay.
Do you drink alcohol?
Right.
And do you drink more than 4 or 5 glasses of alcohol in any one day for a male? And for a female, it would be 3. If they say no to both of those, then we just move on. We don't give them the other test.
Okay.
And there's only 8 other questions.
Okay. And those 4 to 5, that seems like a lot of drinks to me in a day. It seems like they've already passed beyond that intermediate phase, no? Or is that considered
That's the pre-screen.
That's the
Because then,
pre-screen, okay.
if you catch one of them, let's say you
Right.
drink more than 4 to 5, then you go on to the other questions which deal with their ability to
Yeah, I wanted to ask what the other
function,
questions are.
or their dependency
Right.
on alcohol. Do you have a withdrawal? Do you have to wake up in the morning, have a drink?
Right.
Have you had any problems? Has anyone ever said to you, you drink too much? And it just adds up.
Okay, okay. How about the staff? I mean, sometimes it's got to be a little awkward for the staff to be in the position of asking these questions. I mean, healthcare professionals have to ask a lot of personal questions, so we're used to it, but this is a little different than, you know, what are your medications or whatever. Well, I guess it's a form of medication for some
All the
people.
staff are trained.
Right,
Yes.
yeah.
They're trained professionals
Right.
under SBIRT. There's a requirement that they have to follow. And how long is the training?
They took a 4-hour class, actually.
4-hour class, okay.
And it really went through a lot of different things, not only how to ask the questions, how to intervene, how to have interview skills with the patient. So they all have had that training. And they were asking these questions about substance abuse before, so I think that they feel like now they're given a nice tool that can quantify whether if they felt like the patient might have had a problem.
Right.
Now the tool is telling them, yes, the patient has a problem, and we've also gotten a lot of different resources from the community
Right.
and from the National Institute of Health about helping patients look at their drinking.
Do they sense it's making a difference, the staff members? Have you had any feedback from them about this?
I think that some do, yes, because
Yeah.
they like to have that dialogue, and they're actually
Right.
able to talk to the patients about
Right.
it. They really
Okay.
want to feel like they're impacting their health.
What do you think the results are at this time? What are we seeing? And are we detecting substance abuse so far with this? What's the experience?
We have screened over 10,000 patients. at this
10,000, wow.
10,000.
Wow.
Yes.
Yeah. You were even surprised at that number. That's great.
It's higher than that,
Yeah.
and we have about 2 to 3% positive.
Okay.
And what we're looking to see is actually that number should go down, because we want to be able to say that we are making a difference with our brief intervention with these patients, so that as patients continue to come into our hospital, we will see a lowering of the percentage of positive. So we have worked with a few people in getting them into rehab from the emergency department that have been very committed. So that's a very positive thing.
Can you tell me about that? So you've screened the people, you found that 2 to 3% that we've identified an issue. How do you handle it then? What happens then?
To the patient?
Yeah, well, to the staff, what are they do, and then how do we follow up with the patients?
We talk to the patients. We have that dialogue about, you know, do they plan on trying to quit drinking? Do they want to do something? Are they looking for a place to go? We try to get that warm handoff at the very least. Some patients say, you know, I really didn't tell you the truth. I might have fibbed a little, and I really think I need help. And then we now have a caseworker in the emergency department who helps facilitate finding them a place or follow-ups.
Getting them resourced into different programs. And are those programs out there, Dr. Garson, in the community? Do you think there's probably not enough, right, given what the needs are?
I think the programs for the addicted or dependent patients are available.
Right.
Those are the ones like Seafield, Alternatives, Catholic Charities.
Right.
They are organizations that treat patients who really have identified as not just risky drinking,
Right.
but severe drinking.
Okay.
We don't have as many places to send a person who's just a risky drinker,
Right.
because that's really a relatively low level. We don't have organizations. There are plenty of therapists in the community who do psychotherapy and do treatment of patients. But we don't have a good connection at this time. And that's one of our tasks, is to hook those patients up with the low-level, less intense treatment programs.
Do you think sometimes just being questioned about it maybe makes people think about what they're doing? You know, maybe they weren't aware that they've moved up into that risky category, and maybe now it's time to really rethink this?
Studies have shown,
Right.
these multifaceted studies have shown that one intervention, one brief interview
Right.
like that, patients have been able to stop drinking within 6 months.
Okay.
I don't know the exact numbers specifically, but we do know that with SBIRT there was a program, research of 450,000 people. Obviously, this is a federal government program. And they estimated that there was a reduction, this was for both opioids and alcohol, reduction of 60% for the opioids and 30% for the alcoholics in their day-to-day drinking.
Is the data, the questions, is it valuable to the other providers? The nurse, the triage nurse hands off to the doctor, or they end up being admitted, and does this potentially affect the way the doctors and nurses may be treating the patients later on if they know about this?
I think it's a continuum. If the patient's admitted to the hospital, their attending physician then can continue this dialogue and look at ways to help the patient get the help that they need when they're discharged. Sometimes they can have that conversation.
Right. So it's an opportunity to just continue that dialogue.
To continue the dialogue.
Great. We do it in the emergency room. What about other areas of the hospital? Can we do it in other areas of the hospital?
Yes, it can be done in other areas of the hospital. It is part of the initiative that we hope to bring it to all areas of the hospital and then out to Meeting House Lane to the private practices.
Okay, well that's a question also, is can it be done outside the hospital?
Yes.
And what about even in we do public health events, screening clinics, immunization clinics, and talks about health fairs and things like that. Is it something that can be done in that sort of a setting? Obviously, with a trained professional asking the questions.
All those areas can be done, and they're also doing it on college campuses as well.
They are. Okay.
Yes. Any place with a large group of people who just need to be screened.
Right. Yeah, I would think at a college campus would be very effective. I mean, it's when a lot of people begin with their risky drinking behavior, so obviously. And you did mention drugs as a possibility. What about tobacco or other substances? Are the questions appropriate for other potential substance abuses? So.
Well, interesting you mentioned that, because National Health has found that SBIRT is the fourth best public health intervention, besides aspirin, childhood immunization, and tobacco.
SBIRT is really?
Yes.
Why don't we hear about this more? It's interesting.
And it's cheap.
Yeah, exactly.
We're doing fairly well on tobacco, as you well know, and although there's some concern about childhood immunization programs, still that's really the best preventive care. And this is also on that line. We definitely will start to use the DASH, which is for opioid dependency. And that is a program, obviously, the city or the town of Southampton has their task force. And we also at Southampton have a task force to make sure that we are screening and treating opioid dependency as well.
What about things like gambling addiction? Does it work for that, or is it an issue for any other addictive sort of behaviors, or?
The concept of addiction is important. Basically, addiction substances have a way of, we use the term, it has captured the pleasure center in the brain. And these substances can do that, but eating, gambling are also the same type of behaviors, and we see a very similar pattern between those behaviors, and probably they're working on the same pleasure center of the brain, which is a complicated center. Maybe someday I'll come back and we could
talk about that. Exactly right.
The addiction brain.
That would be a very interesting show. Thank you. We're just about out of time, but I did have just a couple of very brief questions. One is, people might be a little worried about confidentiality. Is this something that's going to show up in their hospital record, or is it something that, obviously we take great care to safeguard people's records, but is this information that, how might it be shared, and what should people worry about, so, from a confidentiality perspective?
It's kept confidential like the rest of your medical record. It's only shared with providers that would need that information in your health care.
And anybody has access can ask if they can, we have to notify who we've shared to, and it's only at the patient's request. And finally, just, are there any flaws in the process that you think need to be addressed in this SBIRT process?
I think the biggest flaw is really the human nature.
Right.
Some people are not going to be honest,
Right.
but I like to think that at least they're going to have to think about what they've answered,
Right.
and they're going to start thinking about, maybe I do have a problem.
Right.
But the human nature is the biggest flaw with anything we do.
Absolutely. And it's, I guess it's, the more people we ask, it sounds like the more people we're potentially identifying this behavior and getting them into the appropriate treatment. Well, I would like to thank both of you for the great work you're doing. I had no idea that, particularly your statistic about in terms of the public health benefit of this, it really sounds like something we should be promoting much more aggressively in all hospitals. And I'm glad we're doing it here in Southampton, and thank you both for your leadership in making this happen, and thank you for being with us today.
Thank you.
Thank you.
I'd also like to thank all of you for watching, and if you would like to get additional information about the SBIRT program, or perhaps worried about yourself or a loved one who may need some help with a drinking issue or another substance issue, please feel free to call Southampton Hospital. You can contact my office and we can make the right referral to you at 631-726-8555. We have lots of information on our website as well. I'd also like to thank all of our viewers, and any ideas that you may have for additional programs, please let us know. Anything you'd like to learn about. As always, I'd like to thank our friends at CTV for producing this show and airing it in our Southampton communities, and our friends at LTV for airing the program in our East Hampton communities. Thank you everyone for watching, and good health.